Hi, this is Dr. V. Prakash Rao, Senior International Cardiologist, Care Hospitals, Hyderabad, India. Now we are presenting a live in box PCI of a complex bifurcation lesion with calcification. This is a history of the patient. He is a doctor by profession, aged around 53 years. He is a known diabetic and hypertensive, and he has undergone a PCI to LAD with a drug-eluting stent in 2009 by me only in the past. Now he presented with unstable angina with a dynamic ST changes in inferior leads, and his proper is positive at a preserved LV function. So I have done his angiogram through right femoral approach because he has both radials are hypoplastic. The angiogram showed a patent stent in LAD proximal, and there is a left circumflex dominant and a bifurcation lesion at the bend with the Medina classification 111 with a good sized OM. This circumflex is tortuous and with a visible calcium and fluoro at the lesion site. So, an imaging guided PCI with OCT catheter, a Dragonfly Optimus 6 French compatible, is planned for this patient. The left coronary is engaged with XB 3.5 6 French catheter guiding, and the circ and the OM are wired with the floppy wires cyan blue and cyan wires respectively. The OCT pullback showed a distal vessel diameter of 2.9 millimeter and area of stenosis around 80% and a fibroatherosclerotic lesion with calcium at the site of the lesion and the lesion length being approximately 16 millimeters. The calcium mark is around more than 180 degrees. The depth is more than 0.5 millimeter and the length of the calcium more than 5 millimeter. And there is a calcific nodule also. So a debulking strategy with a rota or lithotapsy is opted in this case. An IVL is preferred in this case because of the short length of the lesion, calcium in depth, and a good sized side branch, which is not comfortable with the rota, and IVL being a more user friendly device. So, a pre-dilatation with 2 into 10 Tazuna has been done because IVL balloon is a bulky one. Difficult to negotiate this lesion with the tortuosity and tightness. Finally, a IVL of 3 into 12 could cross the lesion, and total 5 cycles given at 10 pulses each with 4 atmospheres pressure and kept at 6 atmospheres for few seconds. But patient had a chest discomfort with ECG changes and short length of junctional rhythm during the IVL dilatation, which is expected during the IVL dilatations. A OCT run repeated after this IVL showed there are cracks in the calcium in the intimal and the medial depths, and the vessel expanded to a diameter and the lesion site around 2.86 and proximally around 3.3 and distally 3.06 millimeter. So we decided to deploy everolimus DES expedition 3 into 23. It is deployed at 11 atmospheres optimal pressure, and a OCT run showed after that distal vessel diameter achieved around 8.6 area and the proximal vessel around 8.1 and the lesion area is only 5.8. So at the site of the lesion there is unexpanded stent. So we preferred a OPN balloon which is 3 into 10 and dilated up to 35 millimeter atmospheres pressure. Is finally the lesion yielded and full stent expansion with no edge dissection and side branch well preserved. So this shows a very complex bifurcation lesion in the left dominant circle with a calcium and a bend at the bend. A image guided PCA, preferably OCT, with debulking and a single stent strategy with sideband preservation will have usually a very good outcome. Thank you.